Good, mo Good morning, everybody. It's my pleasure to present this second webinar for the Vasculitis Awareness Month. This is a series of webinars co-organized by RITA and EUVAS about systemic vasculitis. The previous session was on cryogenic vasculitis, and now our session will be on primary central nervous system vasculitis, giving an adult and pediatric perspective. I am Fabio Brandolino. I'm a rheumatologist working in Reggio Emilia Hospital. And here with me is my head, Professor Carlo Salvarani, who is the previous chief of the department. We will do two sessions. We will present the host, and you can write your question on the chat, and at the end we will read the question and answer this, and there will be a discussion. So, Professor Salvarani.
I will introduce the first speaker. It is for me a big honor to introduce Professor Hubert de BOYSSON. Professor Hubert de BOYSSON is an academic internist working in the internal medicine department at Centre Hospitalier Universitaire de Caen in France. His work on vasculitis is particularly focused on junctional arteritis and primary angiitis, central nervous system vasculitis. His studies on primary central nervous system vasculitis has helped to clarify long-term treatment strategies and outcome of this disease. It is a pleasure for me to introduce his talk on primary central nervous system vasculitis, the adult form.
Thank you, Carlo. Thank you for this kind introduction. Thank you, Fabio, for this session. Thank you, Salvarani, for the invitation to speak about primary central nervous system vasculitis. I'm so glad to be there today. So, do you see my screen? Yes? Okay. My disclosures without link with primary CNS vasculitis. Before beginning, I would cite this incredible review article. All you ever wanted to know about CNS vasculitis is shown in this article, and I invite you to read it because it is a very good updated overview of the disease. So, why talk today about CNS vasculitis? Diagnosis is often suspected in patients with an unexplained stroke or with a neuroinflammatory process or with an abnormal imaging with a vascular involvement. But finally, the diagnosis is rarely established. It remains a very rare disease, and the only study we have with incidence shows that in the United States, in the Minnesota, there is 2.4 cases per million inhabitants. And more importantly, we have to know that the diagnosis is sometimes wrong because there exist a lot of mimics, and given the rarity of the disease, there is no standardization of the diagnostic approach, and the diagnosis criteria we used in the past are today outdated. To move forward to the CNS vasculitis diagnosis, there exist some steps to reach. The first is to suspect the diagnosis of CNS vasculitis with a combination of clinical and paraclinical evidence. We have to exclude mimics because there exist a lot of more frequent mimics with inflammatory and non-inflammatory vasculopathies. According to the urgency of the situation, where sometimes you have to start promptly a treatment, if you have a little time, you have to discuss the CNS biopsy because it is the only way to have a certainty diagnosis. And finally, the diagnosis can be accelerated based on the experience of the physician and the expertise of the physicians. And I would like also to insist on sometimes the beliefs that can help or sometimes not for the disease diagnosis. Let's talk about the clinical manifestation. Obviously, there is no pathognomonic clinical signs because it is a polymorphic and non-specific manifestations. You can observe some focal deficits in 3/4 of patients. Headaches are present in half to two-thirds of patients, but first warning, there is no thunderclap headaches in a primary CNS vasculitis, or it is very exceptional. And if your patient have thunderclap headaches and vascular stenosis, think at first at reversible cerebral vasoconstriction syndrome. You can also observe all the neurologic semiology with cognitive impairment, seizure, vigilance disorders. Of course, in a patient with a neurological event, you perform an imaging, and cerebral CT scan is often the first imaging, but I will not speak about it because I would like to insist on the MRI, especially the 3 Teslas tools. Besides the usual sequence, T1, T2, flare, diffusion sequences, you have to ask gadolinium injected sequences, susceptibility sequences to search the microbleeds, the vascular sequences to search some vascular stenosis, and if you have the sequences, parietal sequences, especially the black blood sequences to search an involvement, parietal involvement of the vessel wall. In some patients, you can discuss digital subtraction angiography, but the additional value of DSA is sometimes low when compared to the magnetic resonance angiography. In some patients with isolated involvement of the distal vessels, DSA can be better than MRI to detect small size involvement, small vessel involvement. What can we observe on MRI? In most patients, you will observe some flare impaired intensities in more than 90% of patients. But unfortunately, it is not a good sign because you can find these flare impaired intensities in many other inflammatory and non-inflammatory diseases. It's a vascular disease, so you will observe some infarcts in half to 3/4 of patients with all the semiology of stroke, unique, bilateral, acute, subacute, chronic, deep, superficial lesions are possible. But second warning, be careful, multiple stroke is not suggestive only of vasculitis, and there exist a lot of other more frequent vasculopathies that can cause a multiple stroke, especially in young patients. So multiple stroke alone is not sufficient to retain the diagnosis of CNS vasculitis. Hemorrhage can be observed in 9 to 20% of patients with hematomas or microbleeds and susceptibility sequences that indicate a small size vessel involvement. Gadolinium enhanced lesion is a very good sign of an inflammatory process, and you can observe it in near than half patients. Typically, it can affect the parenchyma or the meningeal, and it should concern regard non-ischemic lesions. Typically, you can perform the biopsy targeted on lesion enhanced lesions. For information, in 5 to 10% of patients, you can observe a tumefactive pattern in the patients, but with this appearance, patients often have a biopsy to search a malignancy, and often vasculitis is a surprise that was not waited. Let's talk about vascular sequences. On MRI, you can observe some vascular stenosis in 2/3 of patients. DSA have a higher sensitivity to detect small size involvement, and you can observe some vascular stenosis on vessel with a caliber less than 500 micrometer. I think that's the third main warning and very, very important for me. Be careful to the neuroradiologist of the neuroradiologist report, because when you ask to your neuroradiologist to perform an angiography, you often induce a cognitive biases, because you ask to your neuroradiologist, does my patient have a CNS vasculitis? And with an appearance such like this photography, with multiple vascular stenosis, your neuroradiologist will respond, yes, it is typical for a vasculitis. But let me show you two other typical appearance of vasculitis. The first case is a man with multiple vascular stenosis and a worsening on vascular stenosis. And this patient have an intracranial atheroma. The second case is a young woman with multiple vascular stenosis and an alternance of dilation and stenosis. And often we're thinking that this appearance is typical of vasculitis. And obviously, this young patient have a reversible cerebral vasoconstriction syndrome. So remember that vascular stenosis that can be observed on angiography can be suggestive of vasculitis, is not typical for a vasculitis because you cannot say on the angiography whether the process is inflammatory or not. The third way to prove the vascular involvement is to use the vessel wall sequences, the black blood sequences. And you can see in case of vasculitis, you have an homogeneous and circumferential enhancement of the vascular wall. But here again, be careful for the main differential diagnosis, which is atheroma, because with black blood sequences, you can observe non-circumferential or non-homogeneous enhancement. And many patients may be diagnosed with CNS vasculitis because of a stroke, a vascular stenosis, and a positive black blood sequences. So you understood there is a lot of high-sensitive findings on imaging, but with a low specificity. So we need some other complementary data to prove the diagnosis. Lumbar puncture should be performed in all patients with a suspicion of CNS vasculitis. It is abnormal in half to 85% of cases. Typically, in CNS vasculitis, the protein ratio is between 0.5 and 2 grams per liter, and the pleocytosis is between 10 and 400 leukocytes. You can, of course, perform some additional analysis on the cerebrospinal fluid. Two important messages. First, it is frequent to observe a mild meningeal reaction after a stroke. And it is not because your patient has 5, 10, 15 cells after a stroke on the CSF analysis that there exists a meningeal reaction. It is often linked to the hematoencephalic barrier disruption. I think that when your pleocytosis is huge, superior to 400 leukocytes, you can observe it in CNS vasculitis, but look at first lymphoma or autoimmune encephalitis. In opposition to the systemic vasculitis with a CNS involvement where CRP is very increased, in primary CNS vasculitis, CRP is rarely increased, and in less than 30% of patients, when it is increased, it is less than 30 milligrams per liter. Let's talk about cerebromeningeal biopsy because it is the gold standard to demonstrate the vasculitis. I don't know how it is in your country, but in France, it is very difficult to obtain a biopsy, and in practice, it is performed in less than 50% of cases. And remember, if you do not have a biopsy, you only have a probabilistic approach of the disease. In France, we frequently here in our center, we cannot perform a biopsy in my center, or the procedure is too risky. In the literature, the rate of complication is around 4%, and it has a good sensitivity with 60 to 75% of positivity. And interestingly, with the biopsy, you can prove an alternative diagnosis with the biopsy. On the other hand, if you do not have a certainty diagnosis, maybe you will cure the wrong disease with a risk of progression, for example, a lymphoma. And obviously, you can observe some treatment-related adverse events in a patient that should not require an immunosuppressant. There is different subtypes of histological pattern with granulomatous involvement, with lymphocytic infiltrate, with necrotizing pattern. All these patterns can overlap. In patients with granulomatous lesion, we have to perform an amyloid staining because it can reveal some cerebral amyloid angiopathies. Obviously, maybe some of these patterns have different prognoses. we try to refine more precisely the clinical radiological presentation of patients with PCNSV. Last year, with the registry, we gathered the data of 153 patients with complete clinical signs, MRI findings, vascular imaging, and lumbar puncture, and we performed a non-supervised cluster analysis, and we identified two clusters. The first clusters were patients with a stroke-like presentation with motor deficit, visual disturbance, ataxia. On the other hand, patients from the cluster 2 show more encephalopathic presentations with seizure and cognitive impairment. Their imaging were quietly different. Patients with a stroke-like presentation showed indeed one or more acute infarctions and vascular stenosis. On the other hand, patients with the encephalopathic presentation showed a small size vessel involvement with microbleeds and gadolinium parenchymal or meningeal enhancement. And interestingly, when we compared the rate of biopsy, positive biopsy in the two groups, we observed that patients from cluster 1 with a large medium vessel involvement and a stroke-like presentation have a poor rate of positivity, a quarter of positive biopsy. And on the other hand, patients from the cluster 2 with the encephalopathic and the small size vessel involvement had a positive rate at 95%. So in the French guidelines, we recommend to mainly propose a biopsy in patients with a small vessel pattern. Here is an overview of the two clinical phenotypes, the small vessel involvement with encephalopathy, seizure, and gadolinium-enhanced lesion and microbleeds, and medium and large vessel involvement with focal and stroke presentation and vascular stenosis. We also discussed last year in the French guidelines with neurologists, neuroradiologists, internists, rheumatologists, neurosurgeons to try to standardize in our country the definition of a positive diagnosis of CNS vasculitis when we do not have a positive biopsy. And we decided to retain the diagnosis of CNS vasculitis in patients with a combination of a vascular sign and an inflammatory sign. Vascular sign, it's a stroke, microbleeds, hemorrhage, vascular stenosis, and an inflammatory signs, meningitis, gadolinium-enhanced lesion, or the parietal positive sequences. Obviously, in some patients with fast progressive vascular stenosis, it can be suggestive of CNS vasculitis. I unfortunately do not have the time to develop all the vasculitis mimics there exist, but there is a lot. And all of them may have at presentation on the MRI some findings that be suggestive of vasculitis. I think that the main differential diagnosis to retain for large and medium vessel, it's intracranial atherom and RCVS. At first, these two diagnoses are very more frequent than CNS vasculitis. And for the small-sized vessel vasculitis, the small perforating arteries, typically in patients with high blood pressure, or the endovascular lymphoma, for example. You know this, when we have the conviction that the patient have a CNS vasculitis, we have to determine whether it is a primary or a secondary process. We have to exclude malignancies, drug and toxic consumption, especially checkpoint inhibitors or cocaine and cannabis consumption. We have to search for infection, especially infection with a vascular tropism, and the huge group of inflammatory disease can be complicated by a CNS vasculitis. Focus on the ophthalmologic fundus that can help for the diagnosis with sarcoidosis, for example, or Bicêtre disease. Let's finish with a word on treatment. 3 years ago, Carlo and I were involved in an European consensus for the treatment of PCNSV, and we did a big work overview of the literature, but I find finally the document is a little disappointing since the level of evidence of the recommendation is very, very low, and for many questions we cannot respond because of the low level of evidence. So let me show you what are our recommendations in France, but it is criticable, and we can discuss about it just after. The therapeutic approach of a patient with CNSV should always include some glucocorticoids, and in most patients, the combination with an immunosuppressant. Probably there exists a little place for GCA alone for patients with non-severe presentation. Aspirin should be used according to the cardiovascular risk factors, and for the ESO recommendation, more largely in patients with a large vessel involvement, those patients with a stroke-like presentation. To achieve the disease remission, cyclophosphamide is the most reported treatment for induction, with a very good remission rate in the literature between 18 and 90% of patients. I will not discuss about the regimen, because there exists different regimen every 2 weeks for the first infusion, or monthly, or even the oral cyclophosphamide, but I do not have this experience. We do not have the experience of oral cyclophosphamide, for example, in France. Rituximab is probably a very good alternative to cyclophosphamide, with 2 different regimens that work to them. And Carlo have a very good experience with mycophenolate mofetil for induction and for maintenance. I think that the other drugs, such as TNF alpha blockers or tocilizumab, there exists some reports for showing their evidence, but the level of evidence is very low. So I don't think that those treatments should be proposed at first for induction. Carlo and I already showed that patients who receive a maintenance therapy have better outcomes, with a reduced risk of relapse and a better functional status at last follow-up. The maintenance therapy can be done with azathioprine, methotrexate, mycophenolate mofetil, or rituximab. And finally, an overview of the treatment. Induction could include cyclophosphamide, rituximab, or mycophenolate mofetil with a glucocorticoid tapering for 12 or 18 months. That's what we do in France, but I know in the cohort of Carlo, glucocorticoid tapering is faster. And we can add a maintenance therapy just after to maintain the remission. Obviously, we have to think about the associated treatment, the prevention of osteoporosis, and the infection prevention with vaccines. So to conclude, I think that typically CNS vasculitis are a group of diseases that required a multidisciplinary approach. In my center, all my patients with CNS vasculitis, I see them in consultation along with a neurologist, because I am not a neurologist, and for the neurological examination, for the reading of imaging, I need the expertise of a neurologist or a neurologist. I think that most patients can enter in one of these 2 radioclinical phenotypes, the small-sized vessel involvement and the medium and large vessel involvement. There exists some overlap, but in many patients, we can enter in one of these 2 phenotypes. Biopsy should, I think, particularly proposed in patients with small vessel pattern. And if we do not have a biopsy, we have to try to retain the diagnosis with a vascular criteria, and if possible, an inflammatory criteria. And finally, in most patients, treatment should rely on the combination of glucocorticoid and an immunosuppressant, but in some patients, glucocorticoids alone can be discussed. And finally, all our knowledge relies on your retrospective registries, and now our registry is open to European countries. So if you are interested to collaborate and to do some collaborative work, you are welcome. Thank you so much for your attention, and I am now open for questions.
Thank you, Hubert, for the very nice and informative talk. We will discuss just at the end.
Thank you very much for the wonderful talk. I remember the colleague attending the webinar to ask questions on the chat, and we will discuss these at the end. It's now a pleasure to introduce Dr. Kumaran Deiva, who is a pediatric neurologist-immunologist leading the Pediatric Neurology Department and the National Reference Center for Rare Autoimmune and Inflammatory Disorder at Hôpital Bicêtre, Université Paris-Saclay. His main interests are neuroimmunopathological mechanism and epidemiology of neuroimmune disease. He participated and coordinated several multidisciplinary clinics and trials on pediatric neuroimmune disease, and is now the leader of the neuroimmune stream within an ERN RITA. One actual aim of this stream is to provide guidelines for the pediatric primary angiitis of the central nervous system in the near future. Thank you, Dr. Deiva.
Thank you very much for this nice introduction. So I'm going to try to complete the presentation of Hubert, and I will mainly focus on the pediatric perspective. So these are my disclosures, and let's start with a clinical presentation. And this is a 5-year-old boy. The only thing that he had in his family history is a grandmother treated for MS. He suddenly presented seizures evolving toward état de mal. So he had many assessments, and among them CSF was normal. There was no oligobuclonal bandings in the CSF, and his seizures were partially controlled. This is the MRI that the patient had, and you can see some lesions, subcortical lesions that are present in the right hemisphere. And then at that time, we thought about maybe an acute demyelinating diseases, and we looked for other autoimmune diseases in this situation. But unfortunately, the patient had many other seizures, and then we had to go and biopsy because the lesions were not typical for other demyelinating diseases, and so we performed the biopsy that Hubert talked previously, and it has shown primary angiitis of the CNS. And this is another story that we had recently, and this boy is 8 years old, and the father was followed for an optic neuropathy. We don't know what kind of optic neuropathy it was, and the child came to the ER mainly because of progressive fatigue and left eye visual impairment, which seems to be an optic neuritis with severe papillary edema. CSF showed a mild pleocytosis, and the other infectious, autoimmune, and systemic diseases were all negative. He was initially treated because when you see the lesions on the MRI, you can see unfortunately the MRIs have been changed in between. The T2 lesion was present on the left side, and there was also a lesion on the lenticular area too, and the GAD enhancing was quite peculiar. So we said maybe it's another demyelinating disease, with inflammatory autoimmune disease, and we treated him with IV steroid with oral tapering. And what we saw in this patient is that although he recovered quite well, he was very steroid sensitive. Whenever we tried to lower the treatment, the optic neuritis relapsed. And another thing is that the new lesions occur progressively, as you can see in these both MRIs. As we were struggling to note what kind of disease it is, we proposed a brain biopsy. Parents were not ready, and as we were told, they said it is complicated, and the neurosurgeon said maybe there are too many risks and other stuff. And finally, we convinced them, and we went for the biopsy, which showed lymphoplasmacytic small vasculitis with perivascular inflammatory infiltrates with parenchymal necrosis with no malignancy and infection. Our idea was to exclude other diagnoses, and finally we had the diagnosis of primary angiitis of the CNS in this patient who was treated with steroid, who responded well to the steroids. So this is a angiography negative childhood primary angiitis. Another story of a child, 5-year-old boy who presented suddenly left hemiplegia with facial paralysis. He had unremarkable family history, and varicella he was infected by varicella 4 months ago. CSF was normal. And this is the MRI that you can see here. And you can see the the right hemisphere was high EPA signal in the right hemisphere with reduced ADC showing those, so a stroke-like lesion with vascular imaging showing also lesion on the MCA artery. So this is something that is called focal cerebral angiopathy, which is not it's still in discussion. We'll talk about it later. Which is different from the primary angiitis. So this is the patient MRI during the follow-up. You can see that the lesion on the vascular lesion has disappeared, and unfortunately, the patient had lesions in the brain MRI, and he had secular, clinical sequelae, motor sequelae mainly. So the childhood primary angiitis is a rare disease also in children. The estimated incidence of strokes, this is a recent estimated incidence of all kind of strokes, more than in children other than the neonates, it's around 3.73 100,000 person years. And among them, it is said, this is again, data are not updated yet on the primary angiitis in children, and it is around 24% of all strokes in children. So there are criteria that have been suggested. The patient should be more than 1 month to 18 years old, and all those three criteria should be met. There should be an acquired, otherwise unexplained neurological or psychiatric deficit. There should be the presence of either classic angiographic or histopathological features of angiitis within the CNS. And the main thing is that there should not be, as you presented previously, no evidence of systemic vasculitis or any kind of disorder that could mimic the angiographic or pathological features of the disease. The key demographic features, again, if we take globally all the primary angiitis, according to the literature, the median age is around 7 to 10 years. There is a male predominance around 60% of boys. Fever can be noticed, and the clinical symptoms are variable, and the three major symptoms are going to be headaches, focal motor deficit, and seizures. But these key demographic features are going to be different according to the presentation of the CNS vessel that is going to be affected. And this is something that is similar to the adults. Either it's going to affect the small vessels, which is going to be called ANCPA-CNS, or the medium or large vessels, which is the APCPA-CNS. And there's going to be two kind of outcomes according to the vessels that are going to be affected. In the medium and large vessels, primary angiitis are going to be either monophasic, non-progressive primary angiitis or a progressive primary angiitis. So if we look deeply on those presentations, the typical age is going to be school-age children around 10 years, 8 and 10 years. Maybe the angiography negative, the small vessels angiitis, are maybe a bit older, but the data didn't show any, it was not significant. If we look now for the sex predominance, you can see the majority in the non-progressive and progressive among the large and medium vessels. There is a male predominance which is present, but in the small vessels, females are more likely to be affected, and this is something different from the adult presentations actually. So the vessel size, of course, we have already talked about. The clinical presentation is going to be also a bit different. It's going to be an acute presentation when it is large and medium vessels that are going to be affected. It can be progressive or insidious if it is small vessels, and if it is a progressive form of the medium and large vessels, it can be also a bit progressive. The main clinical symptoms are going to be an acute neurological presentation, which is speech disturbance in the large and medium vessels affections, while the small vessels are going to be more cognitive and behavioral symptoms that with visual symptoms are going to be present, as I previously presented in the case previously. Headaches are going to be very common in those three situations, but maybe more common in the progressive form with the large and medium vessels affections. So this is the clinical presentations here. And if you look for the assessment that can be done, of course, the MRI is going to be an important assessment. And of course, there is no specific different MRI that can be performed in children, even though the vessel wall imaging is now very, very important to be performed. And you can see here, there is no specific, there are some areas that are going to be affected. If you look for the small vessels, the posterior fossa and spinal cord involvement can be frequent and possible. While in the large and medium vessels rare, maybe in the non-progressive form, it can be possible in the progressive form. There are leptomeningeal enhancement that are frequently seen in the small vessel involvement, and the CSF is also going to be abnormal, most frequently in the small vessels. And it is almost 50% of the children who can have an increased CSF pressure when it is assessed. Another interesting thing to notice is the biopsy. It is in children's non-granulomatous lymphocytic vasculitis, in contrary to adults where it is more granulomatous presentation that can be observed. So the brain biopsy is also needed as in adults. If you want to look for the small vessel vasculitis. So the evolution and prognosis, the large and medium vessel vasculitis, when they are non-progressive, of course, they are going to be monophasic. And if it is progressive, there can be relapsing and progressive. And in the small vasculitis, it's going to be a progressive inflammatory disease. Imaging evolution can show a stabilization and sometimes improvement in the large vessels when they are non-progressive. But they can be persistent with inflammatory lesions in the small vessels, small vessel involvement. Long-term outcome is, of course, with more significant neurocognitive sequelae in small vessels, while it's more likely residual deficit in despite stabilization in the large and medium vessels with non-progressive presentations. So what can we say about the focal cerebral angiitis? Because it is sometimes it can mimic, I won't say mimic, but because there are many debate on saying whether these focal cerebral angiitis are maybe large and medium vessel non-progressive primary angiitis, but still the differences are that it affects mostly younger children than the primary angiitis. It is many times associated with varicella zoster viruses. It is said it's a post-infection, mainly with varicella zoster infection. And there are some typical arteries are affected with the intracarotidal artery and the proximal MCA and ACA arteries that are affected in this specific focal cerebral angiitis. CSF is typically normal. It is mainly monophasic, even though we can see some transient worsening during the first months. The prognosis is favorable, although motor sequelae can be possible, of course, and it is mostly treated with aspirin during the acute phase and even in the longer term. So the differential diagnosis, I'm not going to talk because of the time. There are going to be a lot of different diagnoses, and among diseases that have been already stated by Hubert, of course, the genetic vasculopathy, demyelinating disorders, particularly the ADM presentations, need to be excluded in this, and of course, the mitochondrial and other metabolic diseases. So I'm going to show some. It's not a kind of recommendation, but the treatment proposition that have been proposed in retrospective analysis. So for small vessels, IV steroids are going to be proposed along with cyclophosphamide. And there is also an oral tapering that has been suggested also in this small vessel primary angiitis. And mycophenolate can be put as a relay for the cyclophosphamide on the long term as a long-term treatment. Of course, there is an evaluation at M3. It should be discussed with the expert centers, and then according to the treatment tolerance and clinical evolution, the other proposed treatment that been suggested by Hubert can be discussed with the experts. And this is for non-progressive large medium vessels. Again, the low molecular weight heparin is proposed at acute phase in some centers. But in France, we mostly use the aspirin and the IV methylprednisolone along with oral steroids tapering. And for the treatment of progressive large, medium, and large and medium vessel primary angiitis, it is a similar, but this time we will add also cyclophosphamide and mycophenolate in this presentation. So to conclude, primary angiitis of the CNS in children are rare, but probably under-recognized because sometimes the need of biopsy is going to be complicated, and therefore maybe we may miss some diagnosis. Clinical presentation is highly heterogeneous. Prognosis varies according to disease subtypes. There is an extensive differential diagnosis that need to be done in children. Whenever it is possible, I think brain biopsy may be crucial in angiography negative form. That means the small vessels primary angiitis, and of course, early diagnosis is essential to initiate targeted immunosuppressive therapy and prevent irreversible sequelae. So thank you very much for this opportunity to present these studies.
Thank you very much for the wonderful talk. Now I think we can start the discussion. I will read the first question from Dr. Tang, who asks about how often do patients present with systemic or extracerebral symptoms that can confirm or decide on a CNS vasculitis diagnosis?
Okay, I begin for the adult. It's a good question. The main interest is to determine whether the CNS involvement is isolated or, in the case of question, associated to systemic symptoms. So if there exists some systemic symptoms, CNS involvement indicate a secondary CNS vasculitis. I think that finally, the workup mainly focus in this case on the extraneurologic involvement. I do not have the percentage because it is very different according to which systemic disease we consider. If it is a systemic vasculitis, for example, we know that with the ANCA-associated vasculitis, CNS involvement is probably around 10% of patients. But in other diseases, I do not know the percentage. I think that to respond to your question, that we will retain the diagnosis of CNS vasculitis if we have the demonstration there exists a systemic disease with activity sign. I don't know if it responds correctly to the question, but I unfortunately do not have a precise number or percentage of how often this patient have systemic involvement. And in primary CNS vasculitis, per definition, there is no systemic or few systemic symptoms. And in pediatrics,
I don't have any specific data, neither Hubert, and I think I completely agree with you. If there is systemic presentations or systemic biological items that have been noticed, it's going to be mostly secondary rather than primary.
But the main interest of sorry, Carlo. Go ahead.
Go ahead.
No, I just wanted to add that, Dr. Tang, you're right with your question. In the workup of CNS vasculitis, we have to perform an extra neurologic examination to search systemic symptoms that can lead to a systemic disease, because we know that some systemic disease can begin with a CNS involvement.
Exactly. You're absolutely right.
The second question is, thank you to both for the very nice talks. So
Thank you.
Good.
Good question.
I appreciate it. Going to the third question. The question is the possible role of 7 Tesla MRI for improving the diagnosis of primary central nervous system vasculitis.
Yes, very good. Maybe it will be a very interesting tool, but I want to. I do not have the experience. I think it will be very uneasy because with such precise examination, we will see a lot of abnormalities, and sometimes we will not be able to determine whether it is pathological or not. For example, I think in the last years, the parietal sequences, the use increased, but we are uncomfortable with these sequences because it is not easy at all to determine whether the parietal enhancement is inflammatory or not. Is it inflammatory? Is it atherosclerosis? I think it's very difficult. So I can imagine that with the 7 Teslas MRI, the problematic will be increased, but maybe it will be easier to determine whether it is atherosclerotic lesion or inflammatory. I don't know. But I think we have to increase our knowledge with these sequences. And I don't know, maybe Fabio or Carlo, you have the experience of 7 Tesla or Kumaran?
I agree completely with you. As the only experience, I read an article comparing in general arteritis 3 Tesla with 7 Tesla. MRI, there is no difference in the evaluation of vessel wall inflammation. So I completely agree with you.
Okay. Next question from both speakers. It would be interesting to share your experience regarding the use of plex in plasma exchange in CNS vasculitis.
For me, it will be very, very rapid because I have zero experience. So I don't know. In theory, we do not know any antibodies in CNS vasculitis, primary CNS vasculitis, and we do not know if it includes some immune complex pathophysiological aspects. So I do not know if in theory plex would be efficient in CNS vasculitis. The only experience I have, it was a CNS vasculitis, but in the context of a polyarteritis nodosa, an old case. So I don't know for CNS vasculitis if it works or is it useful. I don't know, Kumaran.
Our experience is that in children, when they had a CNS vasculitis, of course, we did not have the diagnosis at the onset, but in our experience, the patient responded quite quickly with steroids. And for example, the etadmal for patient, for example, normally when they are very, they have many seizures, we need to go quickly, and sometimes we go for plex. But this patient did not needed the plex because he responded to the antiepileptics. When we compare to other, I mean, again, I'm only stating about the primary arteritis, right? So when they are a bit, the pseudotumoral presentations, for example, these can be sometimes very tricky, and we can prepare the plasmapheresis, but in my experience in the patient that we are following, I don't have any patient treated with plasmapheresis, even though they were quite severe in some of them.
I have a question for Dr. Deiva about the use of the rituximab in the pediatric context.
True. Yeah, you're absolutely right, because the number of patients with even though I said 24% of the strokes are maybe a primary angiitis, even though these data exist, the number of patients in whom we have clearly showed with the presence of primary angiitis and biopsy proven, it's really, really rare. So in patient, there are some patients we think that it may be a primary meningitis, and we have treated them with rituximab, of course. So we do have some patients who are treated, but globally we will start with cyclophosphamide and then go, because the data is very rare, but there are presentations that have been clearly responding to rituximab. So if I need to treat, if I had the possibility to treat with rituximab, if it is biopsy proven, of course, it would be easier for me to propose rituximab rather than the maybe cyclophosphamide, but still it is very rare. So yeah, the rituximab is also a possibility in children.
The same questions, two questions. The first one is how do you follow up the patient with primary central nervous system vasculitis? And the second question is predictors of severity.
For the follow-up, it's a follow-up with a neurologist. The first year, it's every 3-4 months, and every 6 months after. I think that the 2 first years are very important to have a regular follow-up of this patient with a regular MRI. And I think after 2 years, if the patient did not relapse and is in a stable condition, we can have a later follow-up. But I think that the 2 first years are very, very important with a regular follow-up and a regular MRI. And but maybe Kumaran, you can respond for the follow-up in children.
Yeah, it's quite similar. I think the 2 years are very important. And in France, in our centers, we propose that there would be a 6-monthly follow-up with MRI follow-up associated. And of course, according to the treatment, of course, if it is, the cyclophosphamide, they are going to come every month, at least for 6 months. And then for the regular follow-up, if there is a long-term treatment that has been proposed. So there would be at least a 6-month follow-up with the MRI, at least during the first 2 years. And then according to the clinical evolution and the sequelae that the patient can have, we will, of course, do either every year or every 2 years, according to the patient's situations.
Can I ask a question on just the value of contrast wall enhancement in the follow-up of the patients? What is useful, is not useful?
It's a trap question. Yeah. If there is an extension, we are very, very satisfied, and it is a good sign. But you're right. Often, gadolinium-enhanced lesions remain positive for a long time, and sometimes it's very difficult to know whether it is a healing process, a remodelage, or a sign of activity. So if the patient do not have any neurological worsenings, if there exist no other new lesion, and the contrast enhancement remain positive, I don't know if we have to increase the treatment. I prefer to have regular follow-up, but not necessarily increase the treatment, because gadolinium-enhanced lesion can remain for a very long time.
Yeah, it's similar in pediatrics too. So maybe we are following yours. The adult protocol. So it is similar to in children too.
Second question was in the same question was predictors of severity of the disease.
I do not show in my presentation. Kumaran did in pediatrician and in pediatry, and Carlo, you show in your studies that the different phenotypes have probably a different severity evolution, and patient maybe with the small size involvement may have a better response to treatment, finally a better prognosis than patient with large vessel involvement and vascular stenosis. And that's why maybe the two patterns should be treated differently with a more aggressive therapeutic in patient with large vessel involvement. And Kumaran, you well shown in your presentation the difference of outcomes and evolution in patients with small and large vessel involvement.
Yeah, you're right.
There is another question about the use of anticoagulation in this patient. Is if this can lead to an increased risk of bleeding.
Yeah. Just go ahead, Hubert.
No, go ahead.
I think that's why I said it is because in two major papers it has been suggested to put the low molecular weight heparins. But there is it is clearly said that it is in the situation where the risk of hemorrhage is low and it's during the acute phase, not in the longer term. It is quickly shifted to aspirin. In France, we are not proposing the low molecular weight heparin or even heparin IV. It is in a very, very specific, complicated situation that we've discussed with the reanimators, and then we'll go for the treatment. But otherwise, it is mostly aspirin is going to be proposed. And heparin and low weight molecular heparins are going to be proposed in specific situations, but again, there should not be, and this question is important. If there is a risk of hemorrhage, you should not at all use that.
Yeah, we have this discussion with the ESO consensus, and there is no data showing that efficient anticoagulation is useful in CNS vasculitis. The discussion exists with antiplatelets, but in a patient with a stroke, with a brain infarction, it is probably dangerous to introduce efficient anticoagulation with anti-vitamin K antagonist or direct anticoagulation. So I would prefer not using this medication in CNS vasculitis. And in a primary CNS vasculitis, there is no, it's not a prothrombotic state. So I don't know, but I don't think that there is a place for anticoagulation, except if there is another indication beside them.
Another question is treatment, regarding treatment. Part induction of remission, do you have experience with infliximab for maintenance of remission, the role of treatment of azathioprine and steroid? I have few experience with infliximab. I think it's not. There is some existing data showing the efficiency of infliximab. So I think it is a possible therapeutic, but on the second or third place, I think after other immunosuppressant. And I say for the primary CNS vasculitis, because in other CNS vasculitis associated with a systemic disease, such as polyarteritis nodosa, such as Takeshita arteritis. So in other Bicêtre disease, we know that infliximab is a very good treatment. Immuran, I don't see, is it azathioprine? Azathioprine, yes.
Yes, okay. Yes. Azathioprine, we have a very good experience in France with this treatment for maintenance, and most of our patients have a treatment, a maintenance treatment with azathioprine, and I think it is a very good treatment for maintenance. For induction, I have less experience, and I would prefer mycophenolate mofetil for induction rather than azathioprine. I don't know, Carlo and Kumaran, your experience.
I think, sorry, please go ahead, Carlo. Yeah.
There is another question about the suspected cases in the GRI area, which is the clinical suspect threshold to treat a patient, and how can you manage a low suspect but still possible primary CNS angiitis? Treating or not treating? It's
yeah,
so easy sometimes.
I think I will do a French response that is not satisfying, but all depends on the severity of the patient. And finally, the main question, what is the severity of the patient? I think a patient with a functional prognosis, or of course with a life-threatening prognosis, but a functional prognosis have a criteria of severity and thus need to be treated. I prefer over-treated a patient with a doubtful diagnosis rather than not treating a patient with a potential CNS vasculitis that can worsen in the few following weeks. So I have, but it is my own experience, and maybe I am wrong, but I prefer have a more aggressive treatment when I'm suspecting a CNS vasculitis. But all depends of the clinical condition of the patient, and sometimes we can wait if the patient only have small lesions on MRI, but no important clinical manifestation. I think we have little place to wait and control again the imaging 3-4 months after. But it is my personal opinion, and maybe I'm wrong.
Yeah, I've shown you the patient, case, the second patient case. The lesion was very low, and this patient, we were just looking whether it's a demyelinating disease or other. But still, the lesion, I have not shown all the MRI lesions there, but there was lesions which was maybe suspect, which could have made us suspect vasculitis. And we waited because the patient had only one optic neuritis and he was fatigued, and we gave the treatment. He looked to recover quite well. But the parents were not for the biopsy. Yeah? We waited for at least 2 years before going for the biopsy. Yeah? So we waited and we treated him as a we waited a bit, but we tried to we pushed the parents to go to biopsy because we said we need to, because he made many relapses and the MRI is not good. So we pushed the parents to go for the brain biopsy, and then we were right. So if it was the similar patient, if he came for an ADM presentation or any kind of severe left hemiplegia, and it was really not very well, and then we would have gone, once we have excluded all differential diagnosis which are quite high, we would have gone for the severe treatment actually for higher for cyclophosphamide, for example, if we really had those lesions which were still compatible with vasculitis.
I think the time is expired. It's 1 o'clock. We had two very, very nice talks, two very good, very nice speakers. I think it was a very interesting session, very useful from a clinical point of view. And thank you very much for this opportunity.
Thank you very much.
Thank you all to you.
Thank you.
We will close now. Thank you very much all the attendants, and I remember you the next appointment next week for EGR vasculitis. Okay, thank you.
Bye bye.